Thank you, Shripriya. Thank you, everyone, once again for joining us. So today, we, as Shripriya mentioned, we are dealing with a different topic, that is psychosocial issues in palliative care. We have touched upon the headings while we started discussing palliative care. I think from the right from the first session onwards. But today we'll be going a little bit. It's a vast area, so I'm sure that we won't be able to cover it, but at least we'll try to uncover some of those areas through today's session. So today we have Ms. Mukta as our faculty. She's a registered clinical psychologist, and she has done her education from Amrita Institute of Medical Sciences, Kochi. She has her own practice in Goa, which is called Manove. Am I pronouncing it right, Mukta? Hope so. Manove, right? Yeah, maybe she'll correct me. So Mukta is also associated with the palliative care center in Ponda, Goa. That's how we met there 2-3 years back. So she kindly agreed to take the session for us today. Thank you so much, Mukta. Over to you.
Thank you. Thank you so much, Dr. Sridevi. Let me just quickly start my screen share.
Mukta ma'am, sorry to interfere, but I believe the voice is very feeble. If you could.
Okay. Is it better now, or is it still the same? Can you hear me?
Yes, ma'am, better now. Can some participants please confirm if the faculty audio is?
Yeah, the voice is still feeble.
Okay.
You increase your volume, no? I think.
Yeah.
Yeah.
Okay, I'm just stopping my video for a while. Just excuse me. Okay, I don't know what is the problem with the speakers because my laptop volume is full. So in case it's really feeble, I can switch to my phone or something.
Now it is okay, ma'am.
Now it's
Yeah,
okay.
it's okay. You can
Now
hear.
it's okay. You can go ahead.
Okay, fine. Fine. All right. First of all, a very big thank you to Palam India and to Dr. Sridevi for this wonderful opportunity to interact with all of you. And thank you to all of you as well for into this field, which is so close to my heart. I understand that all of you are doctors who are new to the palliative care setting, right?
Yes, most of them.
Okay. Okay. But you have been introduced to the basics of what is palliative care. So you have some sort of idea about what it is. Can someone tell me what you know about it? What is palliative care according to you? This is not an exam. I'm not going to judge you based on this. It's just for me to know your understanding and so that I can take it from there. Any one of the participants would like to share with everyone what is their understanding of what palliative care means?
There are a few chats coming up. Are you able to read the chat, or should I?
Yes. Okay. Comfort care, all right. Anything else? Active total care, okay, to reduce suffering, all right. Yes, yes, true, all of that. Basically, if we had to go by a definition, palliative care is treatment which is aimed at improving quality of life of patients and their families who are facing problems associated with life-threatening illnesses. Yeah, it prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether they be physical, psychosocial, or spiritual. This is what the WHO says about palliative care. Yeah. But let's move away a bit from this definition. And instead of theoretically understanding this, let's look at what we do on a day-to-day basis. Even without actively working in a palliative care setting prior to this, working as a medical professional, you have all witnessed people suffering. Is it just physical pain that you witness? What's the first thing that you notice about a person who's suffering from an illness? You go to the hospital, look around your waiting room, what is it that you see?
Anxiety.
Anxiety, okay. Okay, yes. Basically, you notice that they are unhappy people. They look emotionally distressed. Some of them are crying, probably. Some of them look scared, as you said, anxious. Some are restless, probably, pacing up and down. Now imagine an illness that is either degenerative, terminal, or causing immense severe pain. What do you think will happen to that person when it comes to emotional distress that you notice? So we realize that the patient is not only in physical pain, but there's also a component of psychological, social, spiritual pain and distress. The quality of life is really hampered. So to say, they're unable to do things that they once did so efficiently. They're not able to, they're not able to that they did, things which added value to life, like things they food, much that quality to their life is lost or reduced. Okay, I'm sorry, I'm stopping my video because of network issues. Just I'll try and switch it on afterwards for the case discussion. Is that okay? I have
Yes,
low
please.
bandwidth.
Yes, please. Yeah, please.
Thank you. Yes. Okay, yeah. So, and palliative care is all about looking into these aspects along with pain and symptom management, right? So we talk about holistic whole person care as you all have already put in the chat. We talk about psychological well-being, spiritual well-being, emotional well-being, and social well-being. And apart from the fact that illness affects well-being in all these areas, we should also not forget that the mind-body connection is a two-way connection. So just the way the body affects the mind or our emotional state, the mind also affects the body. So very often when you see patients who are in great emotional distress, you'll also see that they have exacerbated perceptions of pain. And hence, psychological, social, and spiritual well-being will also have an impact on the physical well-being. Sometimes even the disease trajectory, like in the last session which we had, people had shared about how pain perceptions of patients had changed after the psychosocial issues had been addressed by the team. And again, the caring is not only limited to the patient per se, right? You are caring for the caregivers as well, their families, their children. Why is that? Why is family the unit of care? What do you think? Why would we want to look at the family's psychosocial and physical well-being as well? because they are affected. Absolutely, yes. Okay, all right. Basically, patient's symptoms and the family's coping are not unrelated. We need to address both because they are interdependent, and it's going to be healthier for both if we address both these issues. A life-threatening diagnosis is traumatic for a patient who is, say, a 37-year-old woman. Yeah. Is it also equally traumatic for her 40-year-old husband, a 10-year-old child, and her aging mother, probably around 70 years old? So here, as we see, the emotional resources, as in the resources to deal with stress, the resilience of the family, and the physical resources, right from money and savings, all these resources of the entire family are threatened, and not just the patient's resources to say. It is a family crisis, not an individual one. Yeah, the patient is not isolated. They're a part of a family system. So the patient's psychosocial and physical health is going to impact the family and vice versa. You might have seen patients with terminal illnesses who have spouses suffering from depression or some other psychosomatic symptoms, where their health also deteriorates. Losses which are suffered by the patient are also losses suffered by the family. Say, for example, we look at a patient's loss of role as the head of the family. It could also be the family's loss of a primary breadwinner. Yeah. So when we look at it, it is a family crisis. In addition, there is definitely caregiver stress. There is exhaustion. There is stress which comes along with caregiver duties, often leading to burnout. There could also be guilt or compassion fatigue. And our role here is to help them vent out, to give them some relief from the stress that comes from being a caregiver. In addition, due to the inadequate understanding about what palliative care is, even a referral to a palliative care service is experienced as a crisis by the family many a times. We have seen patients who who are brought there by some of the relatives, but then they also face threat by their family members who say very hurtful things. They say that you are giving up on the patient, you are being negligent, you're not fulfilling your duties, you're being cruel, you're sending them there to die. There are so many misconceptions about what palliative care centers do. And so the caregivers also have that added burden that comes, and the confusion whether they're doing the right thing by bringing them there. So family-centered care, where healthcare team, the patients and their families have an equal partnership, is going to be the basis of the work that we do as palliative care practitioners. Now, you might agree with me on this, that it's not only a physical illness, that there are other that it's the entire family which faces these issues. But some of you might have a question about why you need to know about it. You're not psychologists or social workers. Probably some of you are psychiatrists. But if not, what will you do? Basically, you need to know about this so that you can do the needful. Since it's a multidisciplinary team in palliative care, we all need to be aware of the possible issues that can arise so that we identify, assess, do our bit to support, and if needed, refer to a specialist. There is a psychosocial dimension to the work of all professionals involved in palliative care, and understanding this will strengthen the practice of any professional working in the field. And even if you can't directly do anything to help them relieve or help relieve their emotional suffering, you can always listen, and never underestimate the therapeutic value of listening empathetically to the story that the patient is bringing to you and what they're trying to tell you. How to listen is definitely something I think that if you have already had a session on communication skills, you might have already spoken about empathy and about active empathetic listening. You need not be able to hand over solutions to them, but just being able to give them a space where they are heard, that's incredibly healing. Now, when I say that, how are these patients going to heal? that is what I'd like to clarify. We are not talking about a cure. Cure is about getting rid of the illness. Healing, on the other hand, is an acceptance of change, to look at themselves in a different light and not as sufferers, to be able to seek their own personal resources to facilitate that change, that acceptance which comes, and to look inside and find the strength to deal with what's happening. That is what I mean by healing. And you can promote it in a big way. All of us who work in palliative care settings can definitely promote healing in a big way. So let's first look at what are these psychosocial spiritual issues which can arise in this context, so that you'll be able to identify them in your patients. And along with that, let's also look at what can be done to assess these issues. Now, it's not really possible to separate out these issues into psychological, social, and spiritual. They can't be categorized very neatly and organized. We can only do it up to an extent because these are pretty much overlapping. So when we're discussing a particular issue, it will have psychological aspects, social aspects, and also spiritual aspects in varying degrees. Yeah, and we'll have to be mindful of that. So the first thing we're looking at is communication. One of the first issues that comes up is communication issues and breaking the bad news. I won't go into the details of it, as I think it'll be covered in your communication session. So instead of getting into the protocol of how to break bad news, etc., I'd rather like to draw your attention to what happens when there is miscommunication about the illness and miscommunication within the family. If it is done hurriedly, if the patient is not given enough time to come up with their doubts and to process this information, it can cause further problems, arguing, non-compliance with the treatment which is provided, especially if people have misconceptions about the diagnosis and the treatment. So supporting and educating the family is really, really vital. It's important that they have an adequate understanding of the illness and the expected process. That we give enough time to address everyone's concerns about it and to help them communicate clearly is very important. Speaking of communication issues within the family, even the most functional of families find it difficult to talk openly about this, to talk openly about death and dying. And they naturally tend to hide feelings and to protect family members from feeling hurt. So they might either hide their distress from each other or hide the news in the first place, especially from children. You might have seen collusion happening with patients. Before I began practicing during my training, a major part of my work was with pediatric cancer patients. And I've seen innumerable such parents. I don't really remember coming across a single parent who didn't hide their own pain and sadness and fear from their child. And they did it to stay strong for their child. But the problem here was children could sense hidden restlessness and anxiety. They knew that their parents were hiding something from them, and that was even more unsettling and scary for the child. And so usually there is no choice about whether or not to tell, especially when it comes to children, because one, they read emotions around them. They notice adults talking in hushed voices, quickly wiping tears. They respond to body language. They can see sympathy in people's eyes. And three, especially when it comes to a parent being hospitalized, they are aware of changes in their routine. They realize that mama doesn't drop me to school anymore. And nobody's really telling me where mama is, when she's going to come back. So honest, open communication in a way that children and other caregivers understand is the key. And we need to help parents see that if they're misguided in their attempts to, protect their children from harm, especially when it comes to younger patients who have been diagnosed with terminal illnesses many a times. So one of our major roles is in facilitating open communication and expression between members and between families and the treating team. The second issue which we come across is predominantly social in nature, and that is loss. The losses experienced by patients could be many. It's not only about loss of a life. It's also about so many other losses in relation to their social world, where the kind of engagement that they had with the world outside home, with the roles and relationships in the family. There could be loss of future, loss of social engagements, loss of roles and identity, as I already said, loss of self-esteem, which is associated with that identity. For example, let's say I'm a teacher. Loss of my role as a teacher, because I can't go to work anymore, is associated with so many things. There is a loss of financial independence, a meaningful contribution to society, a loss of living according to my values, of my confidence in my role. So much of our self-concept is linked to who we are professionally and what we do in a social context. And without that, we might not even know who we are. So that loss is a big one when it comes to people not being able to work anymore. And as mobility and energies decline, it becomes harder to participate in social events and maintain friendships which were built on shared activities and interests. Social isolation becomes a frequent source of social pain for both the patient and the carer. In some cases, it is possible to an extent to get them to meet friends or colleagues, to have meaningful interactions with them. If it's not possible to physically meet them, then at least call or make video calls. But for some of them, many times when it's a chronic illness, the change in the way they feel about themselves because of the illness and their declining function can create a really big gap between their past social engagement and the present limitations and conditions. So for them, probably a solution may be to participate in a new social group altogether instead of trying to integrate back into old groups. For example, cancer support groups, where they can both, learn how others are dealing with the changed identity, compare their own situation, and continue to feel that they can make a contribution. Especially with patients who say that they have stopped talking to people because they hate the look of sympathy or pity in their eyes. There are patients who have, altogether withdrawn from their earlier social circles because of this issue, because they didn't like the way other people were communicating with them, that they could realize that people were hesitant in sharing good news, or they didn't talk about anything else but the illness and the treatment and the prognosis. So that can become really frustrating for the patient. And at such times, it's always better if we could provide them with a new social group which is more relatable to them, because such kinds of experiences could lead to a feeling of being left out or being unable to connect with those who are unaffected and going about their previous routines. And it can also lead the person to withdraw further, which can cause even more pain and hurt. Along with the patients, the carers also have a changed identity. They might be struggling to sustain other commitments, maybe to a job or to other needy family members. They might have kept their life on hold as they put the needs of the dying person first. But ultimately, man is a social animal. You might have witnessed caregivers helping each other in hospitals, striking up friendships. They do so naturally because of their need to connect socially with others. And because they feel understood, they feel a sense of connection. Support groups can help when it comes to social pain, when it comes to loss of social identity and social engagement. Yeah, next comes unfinished business. What does this word tell you? What could be unfinished business? Have you all heard this before? Bucket list, okay, yes. Yes, absolutely. To put it shortly, unfinished business is basically having a bucket list. It can lead to considerable distress, which can manifest in many different ways. It can lead to restlessness, anxiety, discomfort, guilt, helplessness, so many different ways that unfinished business can affect a person's psychosocial well-being. Okay, I can see some more responses in the chat. Responsibilities, yes. Plans which remain undone due to the disease. Absolutely. Yes. Yes. So, unfinished business could be about so many things. It could be about dreams and ambitions, plans for life, as someone said, right from, anything, right? Building their own house, taking care of financial commitments, repaying loans, other responsibilities that they have as parents or as children. So how to identify this? You just have to keep your ears open and you have to notice. If you hear for patients' regrets, you would most likely get to know about their unfinished business. Say, for example, a patient tells you, I wish I had not stopped talking to my sister. And now looking back, it seems like such a trivial matter that I fought with her over when faced with the possibility that I'll never be able to talk with her again. What does this tell you? That reconciliation, maybe asking for forgiveness, is an unfinished business here, and being able to complete that would bring some peace to the patient. Mostly unfinished business would be a major concern in younger patients in their prime, who have children who are small, still studying, not settled on their own, or with parents who are aging. So here the unfinished business would be either revolving around their responsibilities as a parent towards their children, or as the responsibility as grown-up children towards their parents. And in this context, the most common emotional distress would come from the feelings of guilt of not being there for them and anxieties about how the children will cope on their own. Here, let me give you an example of a very strong patient whom we recently lost. I think this example will help illustrate all the 3 points that we've discussed so far: communication, loss, and unfinished business. And it'll also help you see what I mean, that these factors are overlapping. We can't really look at them independent of each other. So this patient, she was a lady in her 30s, diagnosed with CL lung with METs. And when she was diagnosed, it was only to know that it was in the terminal stage, that there were no curative treatments available at this point. It was a sudden, shocking news. She was faced with loss of identity as a young professional. She had to quit her job. As days passed and she quickly deteriorated, becoming dependent on others for her basic needs. She could not take bath.
Sorry
Yes?
to interrupt, the slide is not moving.
Okay. Everybody, is this the issue for everyone?
Yes.
Are you on the unfinished business slide right now?
Yes.
Yeah, I think that's the slide. I think she's talking about UK's story from her own personal experience, which is not written on the slide.
Okay.
Yeah, okay. Yes, so I was telling you about this lady, a patient, and as I said, she was becoming dependent on others for her basic needs. She was not able to take bath by herself. She needed help to walk to the toilet. Such things where there was loss of dignity, especially painful for her to bear at such a young age when, no one is prepared mentally for something like this. There was a loss of role. She had 2 young children, one barely a toddler. And she couldn't fulfill her role as a mother. Her family was extremely supportive. They reassured her time and again that they would take care of her children even after she was gone. So there was no anxiety regarding that per se, but there was the pain of leaving them behind, not being there to see them growing up. It was something she was leaving unfinished. And there wasn't much that could be done to help her complete the task, so to say. Unlike other unfinished tasks, like what we saw in the previous example, reconciliation, which could be easily done, just a phone call would do it. But this was something which didn't have an easy solution, so to say. But what the patient did here was, she asked her child to be brought to the hospital, her elder child, extremely attached to her, 12 years old. And she sat with her and told her how ill she was. She explained to her what a terminal illness means, what stage her illness was at, and she cried with her child and told her she loved her and that she'll always love her. As a palliative care professional, when she told me this, my first thought was that you know, what she did was such a beautiful, difficult, and brave thing to do. But that was not how her family felt. When she was telling her daughter this, her family had tried to stop her, constantly saying that she shouldn't be saying things like this, questioning why she was putting her child through this pain, etc., etc. And that really disturbed her. And she came to me with the question of whether she was being a bad parent by doing this. But somewhere she knew the answer herself, because she told me, I know they didn't want me to say it, but it's the truth. I very strongly needed to say it. And the reason why she decided to tell her child was, one, she didn't want it to come as a shock for her child. She was preparing her child in a way to say bye. And secondly, she said, if I hadn't told then, I don't know if I would have gotten the chance to tell her that I loved her and that I wasn't abandoning her. Here comes the issue of communication. The family was trying to protect the child. They didn't want her to know that her mother was going to go. But even what we see, what research tells us, what studies show is, with children of deceased parents, it is best for the child to be involved in and given a choice to say goodbye. The ideal steps in this situation with this patient for us to follow would have been, one, to find out from the child what she already knew, picking up on the cues that she got from the atmosphere at home. Secondly, to help her mother communicate with her, if necessary, reassuring the mom that this was good parenting, to give her child knowledge of what was happening. And thirdly, help her identify sources of support for the child. And this patient intuitively did all of that. Yeah, she asked the child to come. She spoke, she gave her knowledge about what her illness is and how it's going to go ahead. And what she did was, when it comes to identifying sources of support, the patient's only request had been to help her child through the process of understanding the loss once she was gone and supporting the child through it. That is the only thing she asked of us. And in doing what she did, telling the child and making the request to us, she did indeed take care of her unfinished business to the best of her ability. And when we validated her decision to communicate with her child and assured that we would talk to her, she could give us a genuine smile, and that was the last we saw of her. Many times families are not ready to have this conversation. They would rather protect children, but what they don't realize is, by keeping them ignorant, they're doing just the opposite of protecting them. They're not opening up doors for them to ask their doubts, to prepare themselves for what is to come, and to ensure that they don't blame themselves, which children often do. So moving on, so far we saw communication, we saw loss, and we saw unfinished business. Next is financial problems, a very, very practical issue. As we look into a comprehensive psychosocial assessment, we also inquire about any financial concerns that the patient and the family might have. Many times, as people undergo long treatments over years without any money coming in, drains out much of their savings. Some might be from a poor financial background to begin with. So financial issues is a very, very real concern, as most of you might already know. Why are we addressing it under psychosocial issues? Because it is a source of distress, emotional distress for many. It can even stop them from help seeking. There might be fear and anxiety about it, which again means that they might not respond very well to whatever treatment that is being provided. Especially if these underlying causes of anxiety are left unaddressed. So talk about it with your patients. For some who have been well off until then, receiving charity or asking for help can also be extremely difficult, because it is basically something which leads to a loss of self-esteem for them, that, you know, I have to ask for financial help from someone. What is our role in this as palliative care practitioners? To talk it out with them, listen to their perceptions, how they feel about taking financial help. Is there something that stops them? And secondly, to get them in touch with agencies which can provide aid. For example, at Dilasa, the place that where I consult, we have the Cancer Society aid that's available for families. So generally at admission, the decision makers are informed about it. Again, here it's important that all who are involved in the treatment know about this. Again, to give you an example, we had a patient who got admitted and then kept insisting that he needs to go home. He doesn't want to stay. Very, very adamant about it. He had a young son who was working, but a fresher. And the nurses inquired with the patient, whether he was not happy with the care he was receiving, was his pain not being managed the way he expected it to be. Basically, they were trying to find out what was the reason he was so desperately, just wanted to leave and go from the hospital. Then we realized that he was troubled thinking about the fact that this is a private hospital and it's going to cost a lot and we can't afford it. That was going on somewhere in his mind. And being a proud man, he felt ashamed to share this with the treating team. He told this to his wife though, and then she told her son. Yeah. And now what the son did was, he just kept on reassuring the father that you don't think about it, I'm managing it, I will manage it. Again, this the patient felt was just a false reassurance. That, just so that I continue treatment, right? Now my son is just saying, I'll manage. How is he going to manage? So once he was told about the aid and how it worked, he was much more relaxed. So just ensure that you involve the patient as much as possible in that decision-making process, not just in terms of finances, but otherwise as well. It'll also help maintain their sense of autonomy in their lives, a sense of control. Next, we talk about spiritual issues. Some of these being social spiritual issues as well, with an overlap as we discussed. Spiritual well-being is one of the most important influences on quality of life at the end of life. Patients may experience a number of spiritual issues, including but not limited to a lack of meaning, or guilt, shame, hopelessness, loss of dignity, loneliness, anger towards God, feeling that they are abandoned by God, feeling out of control. There is so much that comes under spiritual suffering. And again, this is not only limited to religiosity and faith, it goes beyond that. As one nears end of life or faces the reality of being mortal so closely, they might begin to have existential questions like, what is the meaning of life? What is the purpose of life? And with that, they might start to think about the past and question about, what did I contribute? What am I leaving behind? And it's important to help them reminisce and look at their past trumps. What have they achieved in life? It could be something very simple as raising three good children of good character, even through difficult circumstances, or being a valued employee of the company where they worked. Knowing what they did was valued is what keeps hopelessness at bay. So this is a time when reviewing the past to put the present in context can be very, very affirming to the person who's dying. This may be done in several ways. For some people, just informal talk with family and friends can give them the opportunity to go over these past traumas and tragedies and to receive confirmation from them that their contribution was valued, indeed is being valued. For some others, a more formal life review may be helpful in settling anxiety and uncertainty. Formal life review processes have been developed in many parts of the world. They are available online as well. If you have, once you start working in palliative care settings, if you have clinical psychologists, which should be the case ideally, working with you, they would be able to do these formal life reviews with the patients to help them make sense of their life and make meaning out of their suffering. We also had, so what I mean by informal talk with family, again, to give you an example, we had a caregiver whose grandmother was admitted, and what he would do, she would constantly be complaining about pain. Her pain perception was really, really high. We just wouldn't, there was hardly any time when she not complain. He came, he sat with her, he was there for 2 days, and what he did was, he asked her about past incidences when she was young, when she was his age, And how did you meet her husband, and all those questions about all positive memories that have already happened. And she didn't once complain of pain in those entire 2 days. She was very enthusiastically talking about her life when she was young. And it is also, such reviews, if you go to see research as well, not just going by anecdotal evidence, if you go to see, it is seen that there is significant improvement in life satisfaction and reduction in stress following such reviews. Associated with life review can also be a wish to leave a legacy or to be involved in planning for the future of their loved ones. So some might want to have concrete gifts that they leave behind, something like a painting or a sari, a recipe book. A parent with young children may wish to leave something even more concrete, something like a letter or an audio tape or videotape for the child to keep and to go back to as they grow up. And you can help them make these things. You can ask other support staff who's working with you or paramedical staff to help them make these sort of memory books with messages and pictures and other small souvenirs that they would like to hand over, or something personal for all the things that they would miss, especially with young parents. Things like the child's birthday, marriage, graduation, when the child would get their first job, if they would like to leave a message for them for those times, something like that. Just, try and imagine, try and go on the other side and just try and imagine if, somebody you have lost has left something like this for you. How would it make you feel? So material which concentrates on demonstrating the value that you had for the patient and reminders of times that you have shared, something like that, if the patient can leave behind, likely to be greatly treasured by the family as well. Making a will, definitely another very, very practical way of ensuring that the patient's wishes continue to carry weight after their death as well. Many times, patients or even families are not very much for it. They just try to keep postponing it or just holding on to hope that they would go back and that they would make the will and things like that. But our role is to just gently nudge them, encourage them, not to force them, definitely, but to make them see reality and as much as possible to encourage them to actually take legal aid and to make a will so that their wishes are respected even after they are gone. Apart from this, spirituality, as we all understand, very simply put, is being connected to something greater than our own self, right? Or being connected to a higher power, not necessarily God always. As I said, not limited to a particular religion. So assessing a patient's spiritual beliefs, assessing the importance of spirituality in his or her life, exploring whether they belong to a spiritual community is something that we need to do. Don't assume that spirituality is or is not important for the person. Really go and ask. And once you have, ascertain how important and helpful it is. A simple question will often be sufficient, just asking whether, is your faith or is your religion or spirituality helpful to you? Or how important would you say this is to you? And then asking them, are there ways in which we can support you in that? Can we help or can we provide you with something or any facilities to support you in your spirituality or in your spiritual practice, if there is any that they engage in? For example, again, a patient at Dilasa reported that he used to visit a local temple every day in the evening. He would go there, and it was also a part of the social fabric of his life as well, where he met his neighbors and he got to speak with them, etc. And after being diagnosed and after he became bedridden, and then he had to be taken to the hospital, and all of that just stopped. So then when we inquired if he had noticed when he was brought in that we had a small place of worship in the hospital, he said yes, but he was bedridden, right? And then we asked him if he being able to go see the idol in the evening and sit and pray there for some time would help in any way? He said yes. It was just a matter of arranging for a wheelchair to take him to the next room. And it had never occurred to him that he could ask for it. And even if he asked, the hospital staff would be willing to do something about it, because according to him, his spirituality had got nothing to do with his illness and his treatment. So, and that is why we cannot assume that if it is important, patients will come and ask, people will come and tell us. It is always better to actually go and inquire actively about it. And, you know, as I said, just a matter of a wheelchair in this patient's case. Interventions need not be complicated, need not be about super brain science. Mostly they just need to be compassionate and humane for them to work. How does this help? How does spirituality help? For those who believe in it, concepts like transcendence, soul, liberation, reincarnation can help patients deal with dying and making meaning out of it. It can also help reduce suffering and facilitate acceptance of the situation. Many times it acts like a buffer against distress, particularly hopelessness. Transcendence, that is a belief in a higher power beyond human existence, often enables connectedness. It removes the isolation of suffering because it places that suffering within a larger landscape. And religious traditions, if you go to see, all religious traditions of the world almost have their own interpretations of suffering, and many also have practices which enable people to transcend that suffering and pain and to make meaning out of it, to make meaning of the suffering that they're going through prayer, through meditation, rituals, so many different ways. And even for the family, if you go to see, rituals following death, post-death rituals, is how the family makes sense of their loss. So many a times these acts of remembrance which come with the post-death rituals help them, it can aid in processing grief for the family. But again, make sure that you're not letting your own beliefs interfere, that you're not pushing the patient in any way to engage or not engage in spiritual practice. It is our job to respect the patient's spiritual orientation or a lack of a spiritual orientation. And if a person is already engaging or would like to engage in a spiritual practice, to encourage that, but never to push those who do not. It's just that we ensure patients are given the opportunity to express their spiritual beliefs and practices, because if they already exist, then they'll definitely be helpful in terms of making sense of what they're going through. Moving on to grief and bereavement. Grief, as we all know, is the emotional response associated with loss. It is an inevitable dimension of our humanity. It's an adaptive adjustment process, one that can be approached with courage if a person is given proper support at that time. As I said, it's an adaptive adjustment process. So it's not, intervention is not always warranted or required. For the majority, although bereavement is painful, their personal resilience will ensure their normal adaptation with the help of family, with the help of close friends, relatives. So normal grief is not really pathological. We need not really do anything about it, except be a supportive presence for them if they need it. And as the patient and family journeys through palliative care, if you go to see, the clinical phases of grief will progress from anticipatory grief through the immediate news of the death to the stages of acute normal grief reaction, and for some, the complications of bereavement which come later. Let's first look at the features of normal grief so that we don't really pathologize that. There would be emotional waves of distress, unavoidable crying, preoccupation with thoughts of the deceased, reduced concentration, other somatic symptoms like restlessness, numbness, weight loss, fatigue, and behavioral symptoms, social withdrawal, seeking consolation from others. Here we just need to be a supportive presence. Let them know that we are available to help if they ever feel the need. But sometimes active intervention is required when we see some abnormal patterns. Yeah. When we talk about anticipatory grief precedes the death. Yeah, it is a result of expecting the future loss, which leads to grief. Yeah, the potential loss is what causes this anticipatory grief. You're anticipating that death is going to happen. There are certain common difficulties which can emerge in anticipatory grief. You might see impaired coping, where family members might either deny the seriousness of the illness. It's, using it as a defense mechanism. They might therefore withdraw, not be involved in the treatment process, or they might show anger. Here, our role is to encourage them to express their feelings openly, to help them recognize that saying goodbye is a process, and that in this process, there are going to be opportunities to celebrate the life of the patient, to express gratitude, to take care of unfinished business, and reminisce on the way. When we talk about complicated grief represents a pathological outcome involving psychological, social, or physical morbidity also. It's basically a prolonged grief with difficulty accepting the loss, meaninglessness, sometimes 6 months or more after the loss, and it's associated with poorer physical and mental health outcomes and increased risk of suicidality in those who are left behind. And this is when active intervention is definitely required. When there is also, a form of complicated grief called inhibited or delayed grief, which is basically an avoidant form of complicated grief, where immediately after the death, the caregivers are not really expressing any grief, but then it comes after a period of normalcy, later delayed. Complicated grief is more likely in untimely, sudden traumatic deaths, definitely, when there is a lack of support systems in place, when there are previous vulnerabilities which exist, and in case of relationships where the caregiver was dependent on the person who is no more. We also have what we call disenfranchised grief, represents the hidden sorrow of the marginalized, for whom there is less social permission to express their loss. For example, if we had to look at homosexual partners, where the society might not really be accepting of the relationship, or if it's not, if it was not disclosed in terms of extramarital relations, there are so many different situations where we see disenfranchised grief. Yes, and coming to psychological issues, we definitely know of what we commonly see in patients. We see anxiety, we see depression, we see adjustment disorders. Many a times we see body image issues, especially with younger patients, particularly with cancer. But and these body image issues many a times also include a loss of attractiveness, issues of self-esteem, self-worth. But if we had to because we don't have enough time to delve into all of this in detail, we cannot put it under the umbrella term of psychological distress or psychiatric distress. Basically, an unpleasant emotional experience of a social or psychological nature that is tied to and interferes with the ability to effectively cope with illness and illness-related treatment. Now, making of a psychiatric diagnosis and the rapid identification of patients in need of help are difficult for many reasons. One problem is that psychiatric symptomatology may be mimicked by the side effects of medication or the disease process itself, and that becomes a problem sometimes. And underdiagnosis and under-identification of psychiatric disorders is very, if you go to see, highly prevalent, mainly because it's hard to recognize in this setting. So being able to identify and assess is very important for all of us. In a drive to address this in the context of, I'd just like to, here is a table for your reference, where it could be of help to, to help and diagnose or to label issues, and if you see any. And but I'm not going into the details of it again, because we might be facing short time. For your, use it whenever you require. And it basically speaks only of the major three, which we see: major depression, anxiety, and adjustment disorder. Doesn't mean that psychiatric disorders are only limited to this much when it comes to palliative care. And as I said, when we talk about difficulty in recognizing, in a drive to address this in the context of cancer care, actually, NCCN, the National Comprehensive Cancer Network in UK, they had the development of brief and rapid screening tools for distress, which can be administered by any professional, need not be a specialist. Something like this, which we have something like a distress thermometer, or we have other screening tools as well. We have something called a face scale or a pain scale, which is easily available online, which can be used by any of you. It can also be used or done by your nurses in hospitals if you train them in doing it. As I said, depression frequently remains unrecognized and untreated, especially because we dismiss it as normal reaction, even in the face of severe affective disturbances sometimes. The most common diagnostic difficulty that arises here in palliative care settings is how to interpret the somatic symptoms that the patients are presenting, especially in the context of a possible depression. The challenge is to determine whether these symptoms are part of the depression syndrome or a direct biological result of advancing illness, especially cancer. So sometimes what we do is we focus on the non-somatic symptoms, especially, for example, irritability or inability to access past good memories. This is something which we typically see in clinical depression, that they're not able to access past good memories. But in a normal grief reaction, that would not be the case. Or even if you go to see, if we had to distinguish between clinical depression and grief, in grief, you would see that most of the time, self-image of the patient won't really change. They'll readily respond to your comfort and care, and they can enjoy pleasurable activities, and they will value authentic connection. This won't be the case if it's clinical depression that you're witnessing. Yeah. So many times the patient might be resistant to the care that they're getting. You will see social withdrawal majorly. They will not be able to express or experience joy even in good memories, and even when they are having a good time. And you'll definitely see a change in their self-image. What I mean by change in self-image is you might see worthlessness, you might see guilt, you might see helplessness, all those things. Now, when it comes to further assessment, as I already said, preliminary screening can be done with the help of face scales, distress thermometers. Apart from that, we have clinician rating scales where we have caregiver burnout scales, we have caregiver problem scales, we have the Beck Depression Inventory, the Edinburgh Depression Scale. There are so many. But again, what is basically you're trying to gauge the emotional temperature of the person here. But again, we have to be quite careful when we're doing it, because not all scales which are otherwise used in general clinical settings are valid when it comes to a palliative care setting. So use them with discretion. the scales that I've mentioned on screen are definitely valid and reliable tools when it comes to using them in palliative care settings. In case of palliative care, many times patients might be unwilling or unable to discuss their symptoms. And in this case, we might go and ask the caregivers. But when it comes to screening for psychiatric issues, it is research shows that asking caregivers is extremely unreliable. Their ratings are closer to their own distress many a times, colored by their own experience and their own perception of the illness rather than the patient's. So, as I said, use these scales, but use them with discretion. Funnily enough, you might not really believe it at first go, but just asking, are you depressed? It really sounds unreal, but studies show that it's one of the most reliable predictors of depression. Just asking directly, are you depressed? And it's always helpful to assess at admission, definitely, but always keep an eye out for appearance of new symptoms, just like you would for any physical changes. And it's always better to be suspicious, I would say, and not risk that depression goes untreated in palliative care setting. All members of the healthcare team may observe, may subjectively report distress that they feel is psychological in nature, like fear or anger, or is psychologically mediated, like pain or breathlessness. But now this may or may not meet the criteria, as I said, of a discrete psychiatric disorder. But regardless of the etiology or regardless of the diagnostic label, it is ultimately about the patient's subjective distress, and we need to help with that. So it's always better to report it. Yes, of course, our work is not only limited to identifying problems and distress when it comes to psychosocial issues, but also to see and help patients see their current support systems, which can help with the social distress, and the internal personal resources and their coping strategies, which are going to be their strength. Definitely, if you have a CP on your team, they can help with that. Here are some final pointers about what our patients really need and what your patients need. The psychosocial aspects of care of the dying person, whatever their diagnosis, will include the need for understanding of their symptoms, of the nature of disease, the process, acceptance, regardless of their mood, regardless of their sociability, regardless of their appearance, self-esteem, being involved, as I said, in decision-making, a sense of autonomy, safety, feeling secure, need for belongingness, wish to feel needed and to not be a burden on others, need for love, expression of affection and human contact, spirituality, as we already spoke about, and hope for an improvement in any aspect of their life or of their living. It need not be hope for a more prolonged life, not necessarily. Here is a link which I would really suggest that if anybody is interested in knowing more about how you can provide hope and how you can be of help as medical practitioners, you can definitely go through this YouTube video. It's really helpful, I would say. There's also another link which I have attached in the previous slide when it comes to diagnosing depression in palliative care settings. That is also a very, very helpful practical tutorial, so to say, which you can start implementing in your hospital setting. But again, as Dr. Sridevi had also mentioned, it's a very vast field. There's very we can't really go into the details of all these when we actually need to. You would really need to be proactive. You'd really need to look more into these aspects and read more on it and all of that. So these are just some references that I have attached, which can definitely help, I feel. Okay. And lastly, some very simple do's and don'ts when it comes to psychosocial issues. Be honest and trustworthy. That's the most important thing that your patients need. They don't need you to tell them lies to comfort them. You need to be honest. Respect people's right to make their own decisions. We cannot force our decisions even when we feel that we are right. Set aside your own biases. Make it clear to affected people that even if they are refusing help now, they can still access help in the future, definitely. You're not going to deny them help if they come later. Ensure confidentiality, definitely, unless you see an active suicidal threat or something that can affect the safety of the individual or others, and provide information. Provide clear factual information, because that's what your patients will definitely be in need of, and cannot get it from anywhere else. As I said, when we say be honest, that automatically includes not to make false promises, to give false information. As I said, them telling their story can be really, really incredibly healing when you listen actively and empathetically. But don't pressure people to tell their stories if they're not ready to do so. Don't judge them for what they're feeling, for their actions in their position. If possible, don't talk about yourself, your personal issues or troubles. Don't tell them that, oh, when my mom was ill, I had gone through so much more and things like that. Please don't do that. Don't philosophize, don't moralize, don't preach. And as we already discussed, when it comes to spirituality, don't impose your own religious perspectives when it comes to spiritual issues. And as you see, most of these needs are not about you being able to provide technical therapeutic expertise, but they're about being a non-judgmental, compassionate presence who is witness to their suffering, who is giving them space to express their distress, and who is accompanying them on their journey. Yeah. So it's just about that. It's just about being compassionate, being non-judgmental, and about trying to help add life to their days and not simply add days to their life. Thank you so much. If there are any doubts, if there are any comments, if there is anything you would like to add or share about your own experience, please go ahead.
Ma'am, can I ask a question? Hello?
Yeah, sure. Yeah.
Am I audible?
Yes.
Okay. So generally, when we talk about memories, reminiscing the past and all that, the good memories, is it acceptable to talk about the good memories to the caregiver, like during the bereavement period? Meaning generally when they're already in grief, is it acceptable to take them back to remembering the good days? Would that be productive or would that be counterproductive?
That is a very, I would say, individualized choice that you would have to make depending on how they are grieving. So because for some it is really incredibly helpful. I think you should let them take the lead. If you see them reminiscing, if you see them coming up with these memories, definitely let them do it, but don't force them to do it if they're not doing it.
Okay, so no, generally it is a natural way to remember all the the good days and all that, but then that is usually immediately followed by crying and they feel low. So which is why I was wondering, is it counterproductive?
Oh, no. So when we speak about crying after this, that, as I said, is a normal grief reaction. That is how they adapt to the loss. Let's not pathologize that.
Okay.
Yeah.
Okay. All right.
Any other question before we move on to case presentation? I think I would like to, not a question, but say comment. I think many a times culturally we don't do all these things. We assume that they may not want to do that, or I think culturally we don't initiate many things, especially legacies. When you go to the Western countries, they do that a lot, making an album or stories or, as she said, recipe books. But we don't actually initiate from our side, thinking that it might be awkward. But it's good to have a try because many a times it works really well. Sometimes people do want to do those things for their loved ones.
Dr. Sridevi, I would just like to add here. I think many a times it's also, we are being very selfish as practitioners. We're just trying to avoid discomfort that it would bring to us when we are talking about these things, and we just talk about all technicalities and jargon and not really get into the emotional part of it, I feel, many a times. Just to avoid that.
Very true.
Yeah.
Maybe even when they're dying, we talk a lot about the process, the prognosis and things.
Yeah.
But then we may ask about the bucket list or what do they want to do in life. Many times we avoid, like I personally avoid those questions in the beginning, I remember, because I don't know whether it is appropriate to ask in our culture. So we kind of, okay, should I ask or not ask, confusion was there. But when you start asking it, then sometimes people do really actually appreciate it. Sometimes they feel odd, they say it's okay, but then sometimes they do appreciate it, and people value that when the loved one passes away. Thank you. I think we'll go on to the case presentation and then we'll take up further discussion. Dr. Shetty?
Yes. Good evening, everyone. I'm Dr. Can you hear? It's audible? Hello, is it audible?
Yes,
Yes.
Okay, yeah. I'm Dr. Shetty Jose. I'm working as a physician at Eastern India Palliative Care, Kolkata. So it's one of our home visit case. It's a 52-year-old male patient diagnosed with glioblastoma multiforme with the right hemiplegia, diabetes, and hypertension. His presenting complaints are repeated convulsion for 2 months, weakness of right and upper lower limbs for 1 month. He cries often for 1 month, severe body pain for 1 month, and bed sore over gluteal region for 2 weeks. It's a diagnosed case of GBM. Debulking surgery and radiotherapy was done in a government medical college in 2017. Follow-up was not done due to unknown reasons. After 4 years, he developed a repeated convulsion, got admitted and diagnosed recurrence. Now he is hemiplegic with bed sore. He makes abnormal grunts, cries often, sometimes with loud noise. His sleep is disturbed, food intake is less, bladder is catheterized, but the urine is clear. On examination, the patient is conscious, drowsy, and is oriented to people, but speech output is nil. His memory and intelligence I couldn't assess. Temperature, pulse, respiration, CVS, abdomen, everything is within normal limit. And the BP is 130/90. CNS, cranial nerve assessment I did not do. When motor nerve, right upper and lower limbs hypertonic, left side it was normal. And reflex also I could not do. Here I would like to say one thing, like I could not elicit severe pain during the examination. It was around, the NRS is only 2 to 3, you can say. When I turned him sideways, he did not make any noise. But while I was writing my prescription, I noticed him weeping. Yes. Next slide, please. And investigations and treatment-wise, blood is diabetic, dyslipidemic, and MRI spectroscopy showed a recurrent neoplastic lesion. I'm not concentrating much on investigations and treatment. Please. And patient is on Levipil, Lacosette, Metexel, Lativa, and Dex, Lasolactone, insulin, and Odoromet. Sorry. Here, psychosocial aspects. He is bedridden and is being taken care of by a male helper in his own flat. He is an electrical engineer who had worked for more than 2 decades in Nigeria, returned following health problems. His wife and 2 children left him ever since the disease aggravated last year. And the informer is his sister, who is a spinster, stays in different apartment, who helps him. Economically, they are well. Even though I insisted his sister to bring him his children, but she was not interested. So now, main concern is the poor prognosis of the disease, helplessness of patient to express the feeling, non-cooperation of family members. So it's a summary: 52-year-old man diagnosed with the GBM, and the treatment was done, and now with the hemiplegic, whose speech output is nil, and he was estranged by his wife and children. Now he is looked after by a male helper. For last 1 month, he cries often, sometimes with loud noise. He is on anticonvulsant, antihypertensive, anti-diabetic, and anti-anxiety drugs. Here, after my analysis, I feel that more than treatment, he is in need of socio-psychological support. So coming to the discussion point, the role of palliative care as a team, reasons for his breakdowns. Is it physical pain or emotional pain? Or what is the score of pain? Then, sorry, what I can't see. What is the management of it? Something I written, I don't know. I can't read it. Whatever it is. Then again, as a physician, psychologist, or a psychiatrist, what is the role of opioid or tricyclic antidepressants? Next slide, please. I think this is the last slide. Okay, here, like, Mukta, I would like to discuss something more because I didn't mention here what is the role of community involvement. That today's discussion, I was expecting something from the community. It's a community involvement. Okay, so that also I didn't put in the slide, but that's also important fact. So now we can help us with your view, how as a psychologist, how you will be able to help this patient, because patient is already bedded and he's in a flat, and it's not easy to go and spend so much time with this sort of patient. But as a physician, how will be able to help them?
So I think what you mentioned is really important here when it comes to community involvement. Especially because if you go to see his psychosocial suffering, there is a lot of suffering related to social losses. Especially when you talk about his wife leaving him and his children leaving him, and that it doesn't seem that there are any more connections, so to say, which can fulfill his social needs.
And also there is an visible obstruction. That means his sister is staying there. She doesn't want, I asked her, she said she will not allow sister-in-law to come inside. Okay, what action we can take?
So I think here then, instead of just trying relentlessly for the same social engagement, we could, as you said, if there is community involvement, if we have volunteers, if we have people who are interested or are able to provide social engagement, that is something that because that's the only way that we can provide any sort of social engagement for this person.
But I go for home visit, but this is a task for us. It's very difficult, So that somehow I think people can make some solution for that. We can advise, and that will be helpful for we people. We are going to interior areas, and if it's private people and affordable people, in a very different situation. But this sort of people, they focus. So I was expecting something like what I will be able to, how I would be able to manage their cycle. It's not the question of treatment.
Right.
Some other support they need.
Right.
Okay, yeah. So,
and many times, are you, I don't know what kind of a setting you're working in, but is it possible for you to have volunteers from the community?
No, I have, no, it's very difficult. Community, you cannot expect Kerala, no, you cannot. It's a very difficult problem, you cannot. So I have some social workers with me, so we go and do the patient, that's all. Let's see the patient.
Okay.
But this sort of things, even I don't think they would be able to manage.
Oh yeah, no, but it's not about, sometimes it's not even about managing. It's just about someone being there around. So and doing simple things which the patient liked. So for example, we had this, if you could do something like, we had tried this at Dilasa also, to approach colleges and students, even students who are studying social, MSW students, psychology students who would be willing to come up as interns or as volunteers, who could go and do something which the patient, you can get from the sister what he used to like. So say, for example, the patient used to like music. Someone to just go and play that music for him. It's nothing much, that person might not even be responding. The patient might not really be responding considering his condition. But we are not
here
doing
we know
it.
No, madam, here we know the reason, because he is missing his children. That's there is no need for much investigation. He's missing his children.
Yeah.
So I just want to bring them, if what, it was pathetic.
That would be the ideal. That would be the ideal solution, ma'am.
Yeah, we know the reason. Then what to do? If we don't know the reason, okay, you can, in general we can talk. But this is the reason how palliate, we can give that. That is an impact we can make. We can some ideas, some helpfulness. If you can help them, that will be definitely beneficial.
Right.
Yeah, sure. Okay, madam, thank you. That's all I just.
I think Dr. Shweta wanted to say something.
Yes. Am I audible? I'm sorry, I'm traveling. That's why I'm asking,
Yes.
am I audible?
Yes, you are.
Okay. I have 2 points here. First thing is that there are some situations where in a family, so here there are 2 children and the wife. So generally, one person or more than one people are the dominant decision makers, and the others generally, even if they're sympathetic, they don't really, they're not able to come forward. So is it acceptable to maybe try and tap into those people who are relatively more sympathetic? I mean, obviously, we in this case, not just about the patient, it would be helpful if somebody can talk to the family as well and find out the reason for the discord that they have. That is one. Second, is it okay if the patient is now missing his children, right? So is it acceptable if somebody like a volunteer, like if you can find a volunteer like that, young people, probably somehow somebody of the same age as the children, they come and interact with the patient, which may maybe give him that slight psychological support? Is that acceptable?
The second solution that you have suggested is, I think, very unique, actually, that, getting someone of the same age, but that can also become a bit,
I mean, no, not of the same age.
To do that, yeah.
Mm-hmm.
No, finding people who are ready to do that can become really difficult, and I don't know how advisable that would be also, to ask a volunteer to do that. Yeah.
Okay. And the first part of it, like if talking to the family and trying to find out what the causes of discord are, and if even anyone, if not willing to talk directly, maybe reconciliate, at least to bring in closure. Maybe his suffering is more about not having a closure, them leaving abruptly when he was diagnosed with the recurrence. So tapping into the more sympathetic member of the family, if it is a situation like that, would that help? Not resolve the issue, but just bring in some sort of closure.
Again, there we will have to be very careful, considering that the patient is not giving us any verbal output. We are going with our assumptions about what's happening or what is going on in their mind. And secondly, considering that the sister is, let's say, the primary caregiver, even if we are talking to other members of the family, it shouldn't feel like or in any way interpreted as we are going behind her back. We need to, so we often have family meetings, where there are these between the family issues, or within the family issues, sorry. We have family meetings. We ask all the members to come and we talk to all of them together. So, but that can become slightly, you'll need to have, it can get out of hand sometimes, especially when you have such strong emotions and opinions about something.
The reason why I spoke specifically about the family is because, like you said, next of kin would be the children and the wife. I mean, the sister does have the right, but then otherwise legally it's still the children and the wife, isn't it? So maybe separately talking to the two of them, like the sister, again, to find out the causes. I mean, the reason why she is not allowing the, she does not want.
Yeah, that would definitely be there. I mean, if you're trying to find out the reasons and the causes behind it, that definitely yes, because you're again promoting open communication. You're not doing anything,
right,
hiding from her or nothing like that.
Okay.
Yeah.
I was just remembering about a recent incident with a patient in our inpatient unit, where exactly the same. She was abandoned by her children, but her only wish was to live with her children at least for a few days. So she didn't have anyone to take care of. She was in the inpatient unit. Like whatever we did, she just wanted to be like what we provided a caregiver from our side. We engaged her as much as possible, but the only wish she had was to be with her own son and daughter. Every time, like we kept talking to the family, but they have their own explanations on why they don't want to take care of her. Then there were not much pressure from our side, but after a few months, actually the son agreed to take her. He took her and she passed away the next day. So it's it may or may not happen, but we can try our best to talk to the family. That is one thing. And identifying someone, like it might be a distant uncle in Kerala, it might be a ward member, some prominent person in the community. Make them understand what it is happening. This patient is not, GBM is not having a good prognosis. So it's not going to be a long-term care to be provided. So involving someone who have the voice, some village leader, like especially we in our culture, we include the ward member because everyone knows them and they have some voice, and then they go to the family and then they talk. Why can't you just, we all will support. Why can't you just take them for a day? Why can't you just go and visit them for a day? All these kinds. So that really helps, like involving someone prominent in the community or in their family. It might be an uncle who is not even related to this person, but these people will be listening to that uncle. So it's better to identify that key person, and when you talk to 4-5 people, you'll understand who is that key person. Then just have a conversation, have them as the mediator, let them talk to them, and that might sometimes work. Then community, yes, as Mukta rightly mentioned, students help a lot, like not for this particular patient, but if you have problem in finding volunteers, generally students are a good resource, like social work colleges or nursing colleges. If you give an awareness about palliative care and the elements of suffering, what they can do. Just we are not asking for big things. We are just asking for them to spend a few hours or just spend some time with the patient. Sometimes they do come up with some music program, some painting. I'm not telling specifically for this patient because he may not be able to do all these things. But it is a good area to explore in terms of volunteering, college students, specifically someone related to like social work or nursing or even arts college. We have a huge support from engineering college students. They have their own palliative care unit. Students are really motivated to do something. Like it is not just in Kerala. I have worked for a brief period in Goa also. Students are a good resource to tap. And finding
Dr. Sridevi, now why can't you sensitize our Anganwadi staffs? Because they are available everywhere in India. And they are doing some help, at least for vaccination coverage, and they are the one coming out in rural areas I'm talking about. Not only in Kolkata, also you can see all like together. It's rural and urban, everything together, mixed culture. But I think what you said is correct. If you can sensitize this urban area concentrated, because they can manage all poor level high and lower level, both people they can manage that, and they will keep an eye on them. At least it would be easier to keep a chain with them. That is the simplest method I think we can place.
So there is already a lot of training programs in the Ministry of Health and Family Welfare that they give for ASHA workers and ANMs in the community. It just happened, Sister Shiva and all just visited Assam for training these workers in the grassroots level to make them understand what are things they can do and what is palliative care. We just finished a program with the Ministry of Health. So that is happening. But our policy is like, wherever you get an opportunity to talk about this for 5 minutes, we do talk about it. For example, tomorrow, our team is going to a tribal area on account of a camp, but then we are taking 10-15 minutes to give awareness about palliative care. So it's nothing related to palliative care per se, but you are getting 10-15 people to listen to you, just talk about it. Then at least 1 or 2 will come and ask you all the questions, and then we can get support from there. So it's all about talking about it. And when you talk, not to take theory sessions, but bring up real stories, real stories, and ask them, how do you think, like Mukta today open the session, what do you think about this? What do you think about the story? What will you do? So then getting them into the conversation rather than teaching them works a lot. So I think you can still just explore, is there any strong member in the family or in the community who can just talk to this family, and separately to the sister and the children. There might be some issues that we can understand when you talk separately. So I think we didn't touch upon the last part of it regarding the medications, but in short, I can say that definitely I would ask a psychiatrist because this is due to that lesion itself in the brain. So I will ask any psychiatrist just to have a look at it and see whether there is anything that needs to be done. In
most of the time, what happens, general physician, they will give high dose of benzodiazepine and make him to sleep. Because no one is to ask.
Yeah,
most
so
of the time,
you have a friend psychiatrist whom you can call. I'm sure in this group there must be psychiatrists, right? So just have friends like me, call them. You just call them, these are the symptoms, can you just come and see? And these days everything is virtual. You can just get a telehealth consultation and just show them this is what it is, these are the symptoms, do you think any medication would help? So we have 4 or 5 psychiatrists over the phone. From home care, we do call them and ask, like, so that's one thing that you can consider for the last. So thank you. I think we overshot time a little bit, but thank you for the wonderful discussion. And thank you so much, Mukta, for the wonderful session also, and sharing your experience. And that is what we can all relate to many times. So thank you so much, all the participants. And thank you so much, Dr. Shetty, for bringing in your case so that we can have a conversation over. Shripriya?
Thank you, Ms. Mukta, for joining us and leading such an interactive discussion today. And I believe that being a different topic, this might have been some new information to at least some of the participants out there. And thank you, participants, for joining. And before signing off, just one gentle reminder that our feedback counts are getting lower day by day. So please take time to leave your feedbacks because it matters a lot to us to improve. I have already shared the link. So with that note, this is Shripriya along with Ms. Mukta and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care, be happy. Bye-bye.
Thank you.